Today the topic is on childhood development, and we'll be learning about how to assess the development of a child when the child is presented to you. So what are the main objectives? So first of all, we should know what is meant by development, and then what are the different areas of development, then on the knowledge on the developmental milestones, and there may be some variance for the development process. It's not very concrete like head control at 4 months, but some children may start it at maybe 3 months and some may go on till about 6 months. So are there any variations to this development process, and if so, how should we accept it? And then to assess the developmental milestones in a child, what are the ways and means that we can assess this development? So when we talk of development, it is acquisition of skills and knowledge. And it is a continuous process from the conception to the maturity of function as an adult. So, once you're conceived, and from while inside the utero, you learn things, as well as the maturity. Well, we say that there's no end to our learning. So it's like that, but when you talk about the development, it may go on for long periods, and that is the maturity that you gain to function as an adult. So during this period, a child would build up stores of knowledge about the environment that they are living in. And then they learn motor skills to survive, such as running, climbing, etc. And also, they will use a language that are native to them to communicate with others and also to think. So then, so what is normal development? So what do you mean by a normal thing? So as I told you before, different children achieve milestones at different ages. So therefore, in development, we also always give a range of achieving milestones. For example, if you are talking about a child walking alone, you would give a range of about, say, 11 months to 15 months. And as I said, so age range is there. And if that age, and these are plotted in charts by looking at several children or many hundreds or thousands of children in a community. And it changes from country to country and also from Asian or African or American standards. They do vary. So sometimes in your books, the different, but of course the age range is more or less same, but some children in Sri Lanka may achieve a certain milestone a little bit earlier or later than in the Western countries. So any deviation beyond the -2 that means that he has not achieved the milestone from the normal is considered abnormal. Of course, there are children who achieve it at a deviation of more than +2 which could be an abnormally good achievement. But if it is less than 2 then it is considered as abnormal. So according to there are published charts. So you know, even if you have not seen anything, you may have seen the CHDR, where they give a published chart of development in Sri Lankan children. With the age matures, the development domains overlap. So and the skills are interdependent. That means that, say, if you have a good vision, you would do a fine motor activity because you have to see to reach for a toy or reach for a small object. So if your vision is normal, then you can't reach. So likewise, you have to have your hearing to have your speech. So they are interdependent. So what are the main areas of assessment? Motor milestones. There are two components to it. The fine motor, like reaching for a toy and picking up a small object or pinch a grass. And the gross motor, which includes the head control, sitting without support, and standing with support, walking, climbing stairs, etc., etc., are motor milestones. Gross motor. So fine motor and gross motor, two main components of motor development, and they are very important. Then the other major component is the language. You might say that the children start talking at 1 year, so why do you worry about language at a very early age? I will show you why. So language includes two parts again. One is receptive, the other one is expressive. Receptive language is what you understand. So say if you understand what I say, that is called that is your receptive language. You don't talk anything. But when you want to ask me a question, you will come out with a question after receiving what I have said. That is called the expressive language. So in children also it's the same. You have a receptive and an expressive language that you develop simultaneously in the process of development. Then the main component goes to cognition. That is the IQ level of a child, which is important for language, for vision, for any activity, as you may say. And then the social interactions and the emotional interactions. Why I have put it in big letters is that because we see a lot of social issues or psychosocial problems or neurodevelopmental problems associated with this condition. You may have heard about autism. I'm not going to deal with autism in this particular lecture, but it's a common and upcoming topic which you will be dealt with within the later, at some later point, especially by the psychiatric colleagues of mine. So when it comes to motor development, it's cephalocaudal. That means it starts from the head and goes up to the toe. So for you to develop the head control, you should lose the primitive reflexes. What are these primitive reflexes? There are primitive reflexes that a child has in your newborn examination. It may have been told to you: the Moro reflex, the palmar reflex, and the plantar reflex. So when you want to achieve motor head control, you have to lose your Moro reflex, because otherwise you cannot have a head control. All the time you will be having a reflex if this Moro reflex is present. So Moro reflex usually disappears by about 2 to 3 months. So your head control comes in naturally around 4 months in a normal child. And what is the palmar grasp? Palmar grasp is when you stroke the child's palm. If you in a neonate or a small baby, you will realize that the baby will grab your hand when you stroke the palm. So that's the palmar grasp. So if you want to see a reacher, the next milestone is the reaching to objects. So if you want to have reaching, this palmar grasp should be absent. So otherwise they can't open up the palm when they see a toy. So likewise, you need to lose certain primitive reflexes to gain the more milestones. Okay, so this is the sequence. Achieving the head control around 3 months, then they achieve the stability of the spine, then sitting to standing, and they also have protective reflexes, like when they try to fall, your arms will extend. So there are protective reflexes. If you have seen a cat landing on the floor, a similar reflex is there in a child as well when they try to land, and all of us do it without any intention. And then the other things are the mobility, like walking, climbing, running, hopping, and jumping, which develops at different ages. So the certain activities like kicking a ball, throwing a ball, catching a ball, or skipping, and also swimming, which needs coordination of legs and arms, and also cycling, are sort of special or the complex activities that needs a coordination as well. So if you don't have the coordination and the balance, these milestones may get delayed. So if you look at the prone development, that is when the baby is on tummy, you can see that initially the baby will just unable to keep the head up, and then he will at one stage will bear weight on the forearms. Then again he'll try to lift the head a little bit more, and then trying to have the weight on the palms. Right, now you can see in this picture, the second picture, that the baby legs are also down. Now in this picture he's kind of kneeling, right? And then here at this stage he can have a balance of weight onto his palms, and then he is crawling, the next milestone. Then he walks as a pair or four-legged posture, and then he tries to stand up to a sitting, tries to stand up with a kneeling down position, holding on to something. Then what about the supine development? If they are sleeping or positioned in their back, you can see that the head control comes in, and then they move to the other side and start looking around, and then they hold and get on to try to sit, and then they sit. When it comes to the sitting, they sit with the arch back, and then with support they may be able to hold the back a little bit straighter, and then with arms help, minimal support, they are holding the back straight. Then the next step is they are sitting alone. When it comes to standing, initially with major support they are standing, and then they might have a major support, two arm support to walk, right, and stand still. And in the walking, again he will cruise first, like holding on to furniture like this, and then with one hand held he is able to maintain his posture in standing, and then one hand held he will be able to walk, and then walking alone. So I have taken fine motor and vision together because they both go hand in hand. So fixing and following. So if you look at a baby, it starts fixing at you and following at you around 2 months, or maybe even a little earlier, like 6 weeks. So that needs coordination. And reaching at 4 months, I told you about reaching for object. You have to lose your palm grasp around 3 months to reach for a toy, and then you have to perceive the depth of it. In what distance this toy is coming from. Like I may be holding it right in front of him. He has to realize the perception of depth, or at what distance that it's coming from. Then different hand movement, and you need a sharp visual focus for a palm grasp. Then transferring of object, mouthing, putting it to mouth, and then the pincer grasp obviously needs a lot of coordination with the eye and hand, and then using the index finger to explore things, right? And casting is throwing out an object. And then the complex tasks like building of a tower, drawing, cutting, you need to control release, and also you need to have some cognition to do all these things. When you're cutting an edge, you have to see the edge, you have to understand what to cut, how to cut, and without cutting the other parts of that picture. So when it comes to hearing and language, I said that language is 2 parts. That's the understanding or the comprehension is the receptive, and expression is the expressive language. So there's an entity called nonverbal communication. Say if you are in a group, and there are ways and means that you exchange your ideas without talking to each other. Supposing a lecturer is doing a lecture, and you're in a group and you want to exchange certain things with your eyes, body gesture. So that is called a nonverbal communication. Language development can be delayed in some patients, or sometimes it could be a disordered language. So when do you think the expressive language begins? It's the startle reflex, when they startle for a huge sound that can be observed from birth. So as early as 0 months or at birth, you can observe the expressive language in a baby. And then they start cooing around 3 months, and then babbling, which includes the monosyllables ah, bah, ka, like this, and also baba, dada, kaka a little later. And then you can observe the distraction test by about 8 months. So that is, you keep a child with the mother and someone distracting him with a toy in front, and you make a sound from the side. And if the child turns into the side, that means you assume that the child's hearing is normal, and then you do vice versa to both sides and to see whether the distraction is okay. But of course, this is a very crude test of hearing, but this is something that you can do in the clinic setting to grossly exclude the gross malformations in hearing. And then you may hear the words from one ear, or even some children might start talking Amma Tata by about 10 months. So that, as I said, there's a very varying, um, very varying, you mean the variations like 10 months to say 1.5 month years. Sometimes they won't talk. So it's a very varying range that you can observe, especially with the stimulation of the child and the environment that he is in, and etc. The nonverbal responses starts about 2 months. That is the responsive smile you have with the mother, and waving bye-bye at about 10 months. So those are things that are examples. And then sentences around 2 years. So they identify the pictures around this year, and also they can do the audiometry called play audiometry by using a special technique at around this year. And the receptive language, again, the social smile around 6 to 8 weeks, and then it responds to name by about 6 to 8 months, and then object permanence by about 8 to 10 months. So that is understanding, and also the situational understanding. So they know that they're at home or they're at a different place by this age, by about 8 to 10 months. And then when somebody says no to something, they know what is no, not to do it. And also sometimes responding to requests like drinking the cup, and also eating, feeding, all these things are when the mother makes a request, they may respond to it. So what is cognition? They are higher functions. So the responsiveness, ability to act purposefully, and object permanence, and non-verbal performances are mainly the parts of the cognition. And identification of strangers at an age of 10 to 12 months will cause a stranger anxiety. If you take a little baby around 4 to 6 months, you may be able to carry him without any problem, even if you don't know the child. But once they become about 10 to 12 months, they have a fear towards you. Unless they know you, they might not come to you to carry. So it's called stranger anxiety. I mean, they may start crying, they may start hiding from you. So that is stranger anxiety, which comes around 10 to 12 months. And then the complex situations, and then they have sometimes there may be a complex situation where you have to understand. So at different ages, different ways of understanding things are there, right? And then you have the pre-writing skills, the number skills, where the children are able to identify which is big, which is small. So if you are given two balls, which is a large ball and a small ball, so that you may have the large ball and you may be able to identify that. And then the colors and the shapes around 3 years of age. When it comes to social and emotional development, it is a complex interaction. You have to have cognition, the language, and the social development. So, but this is the more important thing for you to function in a community, and how you interact and play with fears. So that is very important. So you have to play a good special attention to these key areas and identify if the child is having a delay or not. So how do you assess this development? So there are a series of activities that are developed to evaluate the child's or infant's developmental age. There are formal assessments, informal assessments, and developmental screening. So it will help to identify whether there's a delay and then to try out why and make remedies if needed. So there are tools that have been standardized and for assessment, so which will be able to calculate a score for development and also compare with the norms. So you need to know a little bit about the names. You don't have to know the exact details how they do it, because they are very extensive and nobody can remember it. So the names of the standardized scales are, one is Bailey scales, Griffith scales, and Denver scales, which we use commonly in different clinics. So in one clinic, it may be the Bailey and it may be Griffith in one clinic. But when you talk about these scales, they have different tools that they use. So for you to assess a Griffith scale, you need to have that tool. And Bailey scale cannot be assessed with the Griffith tool. So that's something that you have to remember, that different scales have different tools. But mind you, these are formal assessments. And then, of course, there are non-standardized tests, like as in CHDR we do, they are not standardized. We don't use any standardized tools to assess that, but you just, ask the mother and observe what the child does, and then you get a non-formal or non-standardized testing, like in the ward that we assess in a child with development, and it is useful in a daily practice situations. So these are the kind of toys that you talk about. These things, not everything, but at least some simulation to these toys that I have shown here will need to be there in your development assessment toolbox, meaning that when you come to the wards and you deal with children, always try to assess by using those tools so that you will not remember. You don't have to basically by heart what are the things that you have to do and make it a practice. It's like playing with a child. So this okay. So this is one of the tools that we have, that is the development record, which every child will have in Sri Lanka. So that is one way that you can look at the development. And you have to take a detailed history from a mother, whether there have been any concerns at birth, whether there were any antenatal concerns, etc. And you have to do examination with weight, height, and the occipital frontal circumference. Should not forget that. And then the neurological examination. And if there are any other specific assessments you have to do, and then the relevant investigations. In newborn baby, position of ventral suspension, prone and supine. So the baby will be symmetrical, back will be curved, and arms and legs will be flexed. And when pulled to sit, there will be marked head lag. And able to hear, and I said startle to loud noises. That's the first thing that you would express as a baby. And also able to see, you turn towards diffuse light or just close your eyes tight, and then display the primitive reflexes like Moro stepping and the grasping. So this is called the ventral suspension, where the baby is being held in the arm of the examiner. And you can see that the baby can hold slightly towards the horizontal position, and this is a normal tone of the baby. And this is a normal head lag of a newborn baby, where you know that the baby's head is not controlled. So there is a head lag. And in the prone position, you can see that the baby can lie with this frog position. Then by 6 weeks, he may start following the mother's face. And when you hear a human voice, may stop crying. And He'll start responsive talking with the mother, like going, ooh, ooh, that kind of thing. And then start smiling with the mother. And also in the prone position, he would lift the head up to about 45 degrees. By about 3 to 4 months, head control comes in and there will be hand regard. So this is hand regard, like playing with the hands and the finger play and vocalizing with pleasure. By about 6 months, you can sit with support, not without support, and then grasp and starts transferring objects. And then he may smile and vocalize at a mirror image, and then the monosyllables come in like ma, da, ka, that kind of thing. About 9 to 10 months, cross motor, crawling and standing with support, as shown in these pictures. And then the fine motor, they will have an index finger approach and a pencil grasp. And then waving bye-bye and imitate clapping around again 10 months. And they may even start speaking 1 to 2 words like mama and dada by this age. So by about 1 year, most of it will walk without support and drinks from a cup using both hands. And they will have about 2 to 3 words in their vocabulary. And then they start scribbling with a pencil or a chalk or a crayon. So this is the grasp that they will have when they are trying to scribble. So it's not a proper grasp of a pencil, but of course they can scribble with this. So if you can make out what are the ages. So 3 months, 6 months, 6 months again, about 8 months, 8, 8, 10 to 12, 12, and more than 12, the child walking alone. At 18 months, you can see that the child can start climbing, holding to railings. So even the bear stance happens around this age. And then if you are given a block, like a blocks that are used here, they are like 1 inch, 1 inch, they are standard sizes. The blocks, they will be able to build a tower of about 2 to 3 cubes, and they can hold a spoon and feed. And the speech is about 6 to 8 words now, better vocabulary, and able to show 2 parts of the body when you ask. Around 2 years, they can climb stairs alone, but 2 feet per step. And then the tower, the cube numbers become more, it comes to 6. And then social milestone, they are dry at night, and then they can start about 3 to 4 word or 2 word sentences mainly, and or sometimes some babies will start 3 to 4 word sentences. By 3 years, they may be able to try the tricycle, and they can climb upstairs with 1 foot a step. Downstairs, you still need more support, so both feet per step. Stands on 1 foot, rides the tricycle, and fine motor, builds a tower of 9 cubes, so the 6 cubes have gone up to 9, and they can copy a circle. So when you talk about these different shapes, if you ask them to copy, they are able to copy a circle by 3 years, and cross by 4 years, square by 4.5, and triangle by 5 to 6 years. So this is a rough guide that you may be able to assess their age when you encounter a child. So this is the picture for distraction testing, where the mother holds the baby and the examiner is at the back, and here there's someone taking the attention of the baby, and here's the bell ringing, and when the child looks at that side, if the child looks at that child, then that we know that the right-sided hearing is normal. So I told you about the variation in the pattern of development. So this is the immobile infant at the bottom half, and this baby will start commando crawling. You know how the commandos crawl. So that is a variation. Not all the children do crawl like this. This is a normal crawl, if you can remember how the babies crawl. in all 4 limbs, but here this baby is commando crawling, so maybe using at least 1 or 2 limbs. And then some babies may not even crawl but start bottom shuffling, but ultimately at different ages. So there could be a slightly delay in these children coming to this level. So usual is this baby, the middle. He might come and start walking around 1 year, but this baby may take even up to 18 months to 2 years because he has another way of moving, but no other milestone delay. And even this baby, it may be a little delay. So that is what you have to understand, that there are variations in the pattern which you will have to identify and see why they are varying, and then assess them regularly to identify any other problem. Okay, so that comes to the end of the development assessment and the normal development. So I will come to the next lecture on delay in the development. Then we can see what are the changes in delay.